now we have our next presenter from the University of Sao Paulo in Brazil. And Carla will be presenting on her talk titled Glioblastoma patients treated with allogeneic dendritic cell vaccination may have a shift in their dendritic cells allogenic stimulation capacity after surgery.
So hello, everybody. Can you see my screen?
Yes, we can see.
Yes. Okay. So hello, everybody. My name is Carla. I'm a master student at University of São Paulo, and I'm showing you some results of my master project, that is glioblastoma patients treated with allogeneic DC vaccination may have a shift in their disease allostimulation capacity after surgery. So to start, I want to give you a quick view about glioblastoma itself. So we know that gliomas represent 80% of tumors in the central nervous system, and that glioblastoma is the grade 4 glioma, the most invasive, aggressive, and frequent cerebral tumor. It has some classifications, one based on the genetic signature, proneural, neuroclassical, and mesenchymal, and another one by the World Health Organization based on IDH gene, wild type or mutant. But this last one changed in 2021, as now IDH mutant tumor are now called grade 4 astrocytomas. The treatment for this tumor consists of maximal surgical resection followed by treatment with temozolomide and radiation. But even with this treatment, the survival rate stays between 14 and 15 months after diagnosis, and frequently patients have poor quality of life. So in this manner, we need to develop new therapies to treat this tumor. And the tumor immunology lab, where I'm doing my master, is currently working on an immunotherapy trial with dendritic cell hybrids to try to overcome this poor survival rate. So my part of the job was to see if the vaccine can revert the dysfunctional state of the mold disease in patients and potentially enhancing their ability to activate CD4 and CD8 allogenic T lymphocytes. And the main objective was to determine the MODC capacity of inducing proliferation and if it is restored during the vaccination. As a secondary objective, I looked into the data of granulocytes, lymphocytes, and platelets in the blood of these patients during the trial and see if there was a connection with survival. So first, I want to give you a view about how we vaccinate these patients. So we took the patient with GBM, had the surgery, took the tumor cells and processed them to froze and get samples. Then in a second step, when it's time to give the patient the vaccine, we cultured mold disease from leukoreduction chambers from healthy donors, got the activated mold disease, got them together with tumor cells, and then we have the tumor allogeneic mold disease hybrid vaccine that is administered every month, depending on the number of the frozen vials that we had. So in each month after vaccination, we took 4 ml of peripheral blood of these patients, and we did some assays as the number of cells obtained were allowed us to do. So my focus here was these allogeneic proliferation assays. How I did this proliferation assays. We took the patient's blood pre and post-surgery and pre each dose of the vaccine and a healthy donor's blood. They both underwent fecal gradient centrifugation where we got the PBMCs that went into adherence for 2 hours. For the patients, our focus was the adherent cells, mainly the monocytes, that went into differentiation with IL-4 and GM-CSF for 5 days. And on the 5th day, we added TNF-alpha for maturation, where we got, in the 7th day, mature mold disease that were marked with CFCE and irradiated with 4 or 5 gray. For the health donor's blood, we took the non-adherent cells that are mainly the T lymphocytes, marked them with CFSE, and then put them together in a co-culture for 5 days. At the 5th day, we then marked them for CD3, CD4, CD8, and CD25, and did a flow cytometry analysis. So I'm bringing here the results of the patients that we have most doses of the vaccine. And what we see is that there is a huge variability between each dose and between patients as well. So we see that there are patients that seem to respond in a certain moment. There are peaks of response. So it seems like the MOLD-C regained the ability to stimulate T lymphocytes, but then in some moments it just go down, like we see here. And there are some patients that it seems like the MOLD-C didn't have the ability to stimulate allogeneic T lymphocytes, never in any dose that we had. When we looked at all data together, we have an interesting phenomena. Although there isn't a statistical significance, I'm talking about tendencies, we see that it seems like surgery make the capacity of allostimulation of the DC goes really down, and both for CD4 and for CD8 T lymphocytes. So it's really interesting, and when we think about what's happening, it's maybe the system, when we took out the main part of the tumor, is the system starting to work again, and maybe this is one of the things that will make the patient respond better again. And when we look at all of the patients together, we see that there are kind of waves of response. Here, there is a median with range of the graphs. So we see that although the experimental number of patients is kind of low, we see that there is a tendency to increase in certain doses, but then it goes down, and we see there are some patients that we could give 12 doses of vaccine. That is a lot based on the survival that the patients of this kind of tumor have normally. So what we can conclude of this part of the work is that the tumor removal and the immunotherapy are capable of changing MOLD-C's ability to induce T cell proliferation. We are not sure of what kind of T cells are proliferating and what is happening in general, but it's really it seems like there is something happening. So next, we went into the literature, and I saw that there are some ratios that people see in some kinds of tumors. So with breast cancer, gastric cancer, colorectal cancers, relating neutrophil to lymphocyte ratio with survival and response to treatment. So I went to look at it in GBM, as there is a weak correlation and poor literature in this kind of papers we looked into this tumor. So I looked into the granulocyte lymphocyte ratio and the platelet lymphocyte ratio, as they are potential biomarkers. They are easy and cheap to obtain and follow during the treatment. So what I looked was that the patients in general have a granulocyte lymphocyte ratio are a little bit higher than the normal ratio we would expect from healthy patients. And the platelet lymphocyte ratio stayed also close to normal, to what we see normally. And then I went to look at this kind of correlation with the survival curves. So I took this number, that is the median of our patients' number, and got the 3.35. So patients with GLR smaller than 3.35 seems to have a better survival when we look at second month of vaccination, third month, fourth month, and 5th month of vaccination. But at the beginning, it seems like bigger ratios are related to better survival. So we need to increase the patients to see if we get stronger relations. But it's interesting, it seems like we have something here. With the platelet lymphocyte ratio, it's somewhat similar also. We see that patients with a PLR smaller than 179 seems to have a bigger chance of survival here and here and here and here. But in the earlier months, so with no vaccination and just one dose of vaccination, it seems like bigger ratios correlates better with clinical response, with survival. So it's really interesting data. We need to see this in more patients to see if we can get something really interesting there. The final conclusions that we take of this part of my job is that the tumor removal and the immunotherapy are capable of changing the MOLD-C's ability to induce T cell proliferation. The GLR and the PLR seems to be very similar to the MOLD-C's stimulation capacity, and it might be interesting to investigate these parameters as they are cheap to obtain and follow. And further studies will tell if these changes observed in the MOLD-C's can induce T cell ability to induce T cell proliferation, and the ratios could correlate with the patient's clinical response. So if we put all the data, the immunological data that we have together, we are really excited to see what we can get. Because just to finish and make a little advertisement moment, we have 2 papers published of this work, all the people working on that. And it seems like the patients have a higher survival, a 48-month survival with this vaccine. So it's really interesting. And we are really excited to get into the immunological response, putting together this data with data obtained with other people to see if we can make the correlation between this response and the immunological status of these patients. So we are really excited to see what we get, as this patient here that we related in this one seems to respond really great, and the cytokine profile seems to correlate with the response. So we had a shift in its secretion profile, cytokine secretion profile, and then the tumor recurred. So it was a response that really intrigued us that we didn't see in the other patients. So we are really excited to put all this data together and see what we got. So I'd like to thank you everybody for watching, and I'm open for questions. I'd like to thank all the Tumor Immunology Lab people, all the people that got all this data that I'm showing you, that I analyzed them, University of São Paulo, FAPESP for the financial grant, and BSI for the opportunity to share my work. Thank you.
Thank you so much, Carla. First off, could you just clarify, was the vaccination intravenous? I was wondering if there's a difference between vaccination with the glioblastoma, whether it's intratumoral or intravenous, and whether there's differences in dendritic cell enrichment in different organs.
No, it was intradermal.
Oh, okay.
Intradermic injections.
Okay, okay, can I jump in, or did you have? So great talk, thank you very much, and very exciting to explore this kind of a strategy for an intractable tumors. Absolutely. So when you presented your data, you, beyond the T cells, you looked at ratios, and I'm just wondering, in terms of absolute numbers, did you see post-vaccination increases in neutrophil infiltration, increases in B cell numbers? Did you actually look at absolute numbers and not necessarily related to the T cells, not ratios?
We had the data of the granulocytes, platelets, and hemoglobin levels, because the patients, when they went to get the vaccine, they often brought blood works. But I just looked at them at the granulocyte ratios because it was what we were given, and I wouldn't like to make like percentage of percentages. But it seems like in the granulocyte matter, it seems like they are really close to what we expect from normal people. But there are variations along the work. Of the B cells, we didn't take a look. We just looked at this data that the blood work were given to us.
Okay, you might find in the routine